So the whole idea of this roundtable is there's a lot of new data coming out, both comparison studies as well as even here at ARVO a lot on switching. And what I thought we would do is sort of go over the current landscape of both the diagnosis and management of macular degeneration. So why don't we start with Jason? You see a lot of macular degeneration patients. When a patient first comes in, what are some of the things that you do? What are some of the imaging devices that you use on these patients?
Well, I think the first thing that we have to do is obviously a good clinical examination. Take a good history, find out about the background of the patient, which may play a role in understanding if they truly have AMD. Do a good clinical exam, and then perform imaging, including, for us, photos, fluorescein angiography, and SDOCT, pretty much on all of our patients. Look over all of that, make a determination as to whether, in fact, they do have AMD, if it is exudative, the nature of the pattern of leakage, and then make a decision on initiating treatment.
So, do you think it matters at baseline as much as it did in the past to get a fluorescein?
Well, my practice is to get a fluorescein at baseline and use OCT to monitor therapy. And only repeat the fluorescein if the patient is not responding the way I would expect. But Jason mentioned something very interesting. I have a story just this week of a patient who came to me in second opinion and had hemorrhages in the macula, had some swelling on OCT, never got a fluorescein, and was treated with intravitreal Kenalog for branch retinal vein occlusion and secondary macular edema. Patient came to me, and I saw hemorrhages, I saw swelling, but it didn't look like BRVO. And I got a fluorescein angiogram, and the patient had a beautiful, classic choroidal neovascular membrane. So OCT is critical. I use a lot of OCT, but there is a distinct and very important role for fluorescein angiography, especially to tease out some of these conditions, which may not always be wet macular degeneration.
So, a lot of OCT could show many things that you find on fluorescein angiography, and especially in light of the ACA, Obamacare in the future, where we may be asked to do less and less imaging. Do you think we can cut out fluorescein imaging at this point, or are we not at that point?
I think retina specialists can take very good care of patients with just OCT. The vast majority of patients, in fact. But fluorescein gives us a unique perspective of the lesion. It gives us the geography of the lesion. It gives us an idea of the perfusion characteristics. It gives us an idea where the lesion is located relative to the fovea. When a patient's not doing well, fluorescein can help give us the answer in RP rip, for instance. I would hate to see the day where fluorescein angiography is not part of the management of wet AMD. It really does give me a unique perspective, but I think the vast majority of patients, we can take very good care of them with OCT. In a year, maximum, I do 2 fluoresceins, maximum, and there's some that only get 1 fluorescein in a year. So the burden from fluorescein is minimal, and I think at baseline it does make sense, but I know there are many of our colleagues who don't do it and take very good care of their patients.
So New York, Chicago, not so many Asian patients. Until you're in San Diego, a lot more Asian patients. Do you add ICG at baseline? Is that part of your standard package, or only when you see a problem?
Just going back to FAs real quick, I probably only get FAs maybe on 10% of new wet diagnosis AMD patients and rely mostly on OCT and clinical exam. The only time I really get an FA is if it's an atypical presentation, say like a 45-year-old, or they're unequal disease, one eye has very mild findings and it's advanced, or it's a second opinion patient. Otherwise, FA's really fallen off the map. For Asian patients, like you mentioned, if you're concerned about other etiologies, start out with OCT, and if it looks characteristic, like, it's not polypoidal or RAP or any of the other lesions, probably try anti-VEGF, but if you don't get the expected response after maybe 2 treatments, then I go to FA and ICG. Okay. But unless they fall outside of the range of what you expect, typically go with OCT and clinical exam for the majority of patients.
So you mentioned an interesting thing, which is that you have baseline features on OCT that are kind of helping you figure out management. What are some of the features you're looking for in OCT, for our listeners here that they should be looking at?
You want to compare both eyes. Spectral domain OCT, typically looking for, intraretinal fluid, subretinal fluid, pigment epithelial detachments, things like that. And you base that with your clinical exam if you see like any hemorrhage or thickening, and the patient's own complaint of if they have any metamorphopsia or symptoms. And you put that constellation together to kind of come up with a diagnosis. If there's any inconsistency in those, I think that's where FA comes in, and you're like, okay, well, let's use an FA to help push us one direction or the other. but it's pretty it's relatively uncommon that it goes to that. It's usually fairly clear cut.
So Justice, you're a big OCT guy. What scan patterns do you use? What are you looking for? Do you track your images? So if you're getting a baseline image, you make sure you do this with tracking.
So, I think for me, I'm predominantly using the Cirrus system. I go to one satellite as well as our main institution. At our main institution, we have essentially every OCT device out there. But it is nice when you have a patient who's going from one place to another to have a consistent device for comparison for doing change analysis and registration. So I do that. I think it's important. I think one of the challenges is that when we see so many patients, how do we quickly make both the correct decision and an accurate decision to give them an efficient way out of our clinic, but also the most appropriate treatment as well? And so, it's challenging often to go line by line through the cubes, which I think is certainly important in some cases. But the way I currently use my scan patterns is I get both the macular thickness analysis with the cube, but also horizontal and vertical rasters and change analysis as well when looking at it.
And when you get the cube, which I agree, I think the cube is a great thing to do you actually go through the cube, or do you rely on your photographer to sort of choose one representative image to decide about treatment?
It depends on the situation. We're actually looking right now at reviewing our scan patterns and what's our sensitivity and specificity, what is our under-treatment or even potentially over-treatment on these. I, right now, and initially often start out with PRN treatment, so capturing fluid. Some of the results we're going to talk about is the number of times fluids missed, and so it's something that I'm hyper aware of and wanting to look at what can we see with different patterns that allow us for a rapid look. The fact is that depending on your center, you may not have access to reading software, which is the only real way to go through the cube line by line. And so either you're going back to the device or pulling it up. So in most cases, if it's pretty clear, I'm not necessarily going line by line. Again, if you actually look at the thickness map and there's an area that looks suspicious and you don't see signs of fluid, then I will, go to that area on the cube to see what are we seeing there.
And you say use change analysis, which is great. What are you looking for in a change analysis? Is just colors, or are there certain patterns that you're looking for?
Well, again, when I have a patient who's coming back in, I'm looking at vision, I'm looking at the exam for any signs of new hemorrhage, new edema, and then looking at the OCT for change. When we look at the results that we're going to talk about, under treatment is certainly not something you want to be doing. And so if I see any signs of subtle change in thickness, whether that's 5 microns, less than 10 microns, that's an area that I really want to look at line by line to see is something going on early on. Whether I decide to treat it, often is a discussion with the patient. If it's definitive fluid, that's something that we're certainly going to treat. But I really have found the change analysis to be useful in those regards in terms of really targeting where you're looking back at the scans.
So Jason, you run a reading center. How often is that change analysis, especially in a setting of AMD, correct or incorrect?
Unfortunately, incorrect often enough that it's suspect, and I think being cautious about using just change analysis is important. In our office, we almost universally go through line by line, quickly, mind you, but we go line by line because we just don't rely on either the change in the change analysis or in the central macular thickness numbers. There are many times when things look completely stable, the numbers are unchanged, there's no difference on the automated detection, and yet going line by line, you see a few tiny intraretinal cysts or a little bit of subretinal fluid, and we know that especially intraretinal cysts may be very, very critical in some of these outcomes. So I think it's worth the few extra seconds it takes to go line by line, scan through them, and look for any findings. You can always stop and look, but you can go fairly quickly comparing the two to see if there's a difference.
Jason, do you have reader software in every room?
We have access to reader software through a server, yes. So
and that's often, that's the challenge. At our home institution, we have the reader software, so it's very easy to pull up and go line by line. Whereas running down an entire floor to do that, if you don't, makes it a logistical issue. I think for a lot of practices.
Yeah, I think that really reader software is critical. Yes. You really have to have the capability while you're sitting with the patient, going through line by line. And the other key point is there's nothing better to teach a patient And in fact, some of the patients, I'll walk in the exam room and I'll find the patient scrolling down their images themselves, already looking to say, hey doc, I think there's a little cyst here on line 18. And I'm like, yep, you're right, let's get a treatment.
Well, in ACA, that'll work very well. You just give the patient their OCT and ask them to read it. Do you need a shot? Yes, no?
Hand them the syringe and they go to work.
I think, for me, I think that patient education tool is also a critical part of it. We have big screen monitors in every room, and actually with every single patient, I go through their OCT at every visit, usually before I examine them, so they're not bleached and they can actually go through it with, and I think it's a really good way to engage them in whichever treatment regimen you're doing.